Hello, everybody. I'm really sorry. I don't know what's going on today, but the connection here in the hospital, I don't know. I don't think it's the COVID situation which makes everything more difficult, but definitely we have to go in face-to-face meeting as soon as possible. So I'm really happy to be not here with you today, but connected with you. Yes, to discuss about the DAPT challenges after PCI. So I really tried to keep the presentation as practical as possible, and to start with a very short introduction. Maybe one of the most important messages from the recent studies that we have to tailor and to find the optimal DAPT for one single patient. We have to look at the bleeding risk of the patient. We also have to look at the ischemic risk of the patient. And finally, we have to look at what we are doing in the cath lab, meaning in terms of PCI complexity. And accordingly, we should not use the same DAPT strategy for all patients, but we have to do more and more individualized medicine. But also when we are doing PCI, like the one which is now done in the left main and in the LAD, just at the end of the PCI, we usually report on the file the post-DAPT strategy, let's say a priori. But we know that DAPT strategy will be dynamic decision because during the follow-up, some patient will experience side effect. Some patient will experience outcome. And accordingly, we will have a final DAPT strategy, which will be the modification of the DAPT strategy a priori impacted by the tolerance and the patient outcome. So at the end, we know that we have one disease with two different presentations, the chronic coronary syndrome and the acute coronary syndrome. And the chronic coronary syndrome, most of the DAPT decision will be based on the PCI itself because we have stable patients. While in acute coronary syndrome, we have thrombotic lesion, unstable patients, and I think we will more decide the DAPT based on the clinical presentation. And at the end, I think we have to see two different types of DAPT indication. The first one is for the stent, which is the minimal DAPT for the prevention of stent thrombosis. The second one will be the optimal DAPT for the secondary prevention and prevention of atherothrombotic event. So the short DAP is possible with the nude stent, but still we might need longer DAPT for selected high-risk patients. So just after this brief introduction, I will just try to follow case by case and to start to see different clinical scenarios. So first, when we put drug-eluting stent for patients with chronic coronary syndrome or stable coronary disease, let's just start with one case. It's a 52-year-old male. He has chest pain, positive CT scan with a stenosis of the middle AD, and is a smoker. So here you can see on the right part of the slide that this patient had a critical lesion of the LAD, which was a single vessel disease. And accordingly, he was treated with a long drug-eluting stent with a good final angiographic result. And so it was a kind of standard patient. And accordingly, for stable patient with drug-eluting stent, let's say that the rules or the standard of care is to give aspirin and clopidogrel for 6 months. That's the rule. But sometimes it's not exactly like that. We can have, again, a stable patient, 61, chest pain, but with prior history of coronary artery disease with STEMI, and he has anterior wall ischemia on the MIB, and it's a diabetic patient. You can see here that he had the instant CTO of the right and the critical ostial stenosis of the proximal LAD. So we will not discuss too much, let's say, the techniques, but still this patient had quite complex PCI of the left main and the proximal LAD, which was OCT guided and with a good final angiographic result. But of course, for this specific patient, he was a little bit higher risk than the previous one. So this patient was not discharged just with aspirin and clopidogrel, but with aspirin and prasugrel for 1 month and then switch to clopidogrel. So that's a kind of patient in which we want to give more than the standard and to start with the potent P2Y12 and then switch to clopidogrel. And such patient will probably have more than 6 months of DAPT. But we also have patients on the opposite, like this one, 72 years old patient, prior bleeding, liver disease, low rate of platelet with positive stress echo. And this patient had almost the same lesion than the previous one, which was critical lesion of the ostium of the LAD. And as you can see, we had, again, a PCI with the left main. And of course, in this specific patient, he had a much higher bleeding risk, but still high ischemic rate of bleeding complication. So accordingly, we decided to give less and to give 3 months of DAPT for this patient. So just these 3 cases to summarize that in stable patient treated with drug-regulating stent, 6 months of aspirin clopidogrel is the rule. But we can sometimes give more in high ischemic risk patients or give less in patients with high risk of bleeding complication. So it's a good illustration that it's individualized medicine, and in stable patient, it's not one size fits all. And it's exactly the same in acute coronary syndrome. If we take a straightforward case, 51 anterior MI with multivessel disease, this patient had ST elevation in the anterior leads. He was treated in the pre-hospital setting, and he had occlusion of the proximal AED treated with drug-eluting stents. And this patient was a standard post-ACS patient, and he had aspirin and ticagrelor or prasugrel for 12 months. And many of these patients, as you asked in the question before my talk, will have longer DAPT. But also in ACS patients, sometimes we have clearly patients with high bleeding risk, like the one which is currently treated now in the hospital. This patient, 81, atrial fibrillation treated with NOACs and complex PCI. Of course, we had here elderly patient with oral anticoagulation, so very high bleeding risk. And accordingly, this patient had a different discharge DAPT strategy, with anticoagulation, aspirin, and clopidogrel for less than 1 month, and then de-escalation by stopping the aspirin. So it's a kind of patient in which in ACS we will give less with aspirin and clopidogrel. So also in ACS we have the standard of care, which is aspirin and potent P2Y12 for 12 months, but sometimes we will do much less in patients with high bleeding risk, and we will just discharge the patient with aspirin and clopidogrel. But do we have something in the middle, let's say the intermediate way? Yes, we do, because in high bleeding risk patients, as we said, we will just give clopidogrel and there will no space for de-escalation. In very high ischemic risk patients, like the one we've described, diabetic patient, multivessel disease, it will have the guideline strategy with 12 months potent DAPT. But in the middle, we will have a significant proportion of patients who will be good candidate for the de-escalation strategy, meaning not to keep the same DAPT for 1 year. And of course, on top of that, we will have some patients with side effects. So for the de-escalation strategy after ACS, the concept is the same, is to reduce the platelet inhibition during the first year after ACS to reduce the risk of bleeding complication. The question is about the optimal timing, 1 month, 3 months, or tailored, and how to do the de-escalation during the first year after ACS. We have many options coming from recent scientific studies. The first one is to give ticagrelor monotherapy without aspirin at 3 months, like it has been tested in Twilight and TICO studies. Or we can decrease P2Y12 inhibition by switching strategies, as we used in the TOPIC study, or just reducing the dose, like prasugrel in the recent Lancet published study. Or we can even stop DAPT before 1 year. And Just one patient to illustrate this strategy. It's patient with high bleeding risk, but also patient with high ischemic risk. For this patient, we want to keep clopidogrel because of the high bleeding risk, but it's a STEMI patient, diabetic patient with multivessel disease, and accordingly, we want to give prasugrel. So we had to find a kind of compromise with the early potent DAPT with aspirin and prasugrel, and then de-escalation to clopidogrel after 1 month. So just to summarize, we can say that today, to try to make it simple, we need to have individualized approach based on patient and PCI characteristic. And we have the rule, let's say the standard approach, but often we have also variation from the rules. And as we've seen, there will be a strong impact of oral anticoagulation therapy background. So just to try to put everything on one slide, for stable patients treated with drug-eluting stent, the rule today is aspirin and clopidogrel for 6 months, but sometimes we can do more aggressive treatment and longer duration, but sometimes also we will use shorter duration in patients with high bleeding risk. And also for ACS, the rule is to give aspirin and potent P2Y12 for 12 months, but in patients with high bleeding risk, we will give aspirin and clopidogrel for 1 or 3 months usually, and we can also choose the DAPT de-escalation during the first year after ACS. And now we have, I think it was the last slide. Thank you.
Thank you so much, Thomas, for your overview. It's a very nice overview. Keep it simple is the rule. Sometimes it's not so simple, but you put this in a very nice way. So we have a panel to help us to discuss all of these topics. The panel is Jorge Guardado, Jorge Alcravelo, Hugo Vinhas, and Vitor Matos. They are going to help us to discuss not only your talk, but also the responses of the televoter. All of this discussion is around antithrombotic therapy in ACS patients in chronic situations, in high bleeding risk, low bleeding risk. So let's move to the panel. Who wants to start? Probably Jorge Guardado is in the studio, and then we can move for other colleagues that are at distance.
So
Jorge, can you start?
Yes, João, I think we are ready to move to Jorge Guardado, but we'll have still a televoting question that will launch now.
Oh, yes, sure.
That will just launch to tease the audience regarding what we have at this stage. So this is a question that is completely on the line with the presentation that we just saw. You please vote now. This is the question is in a coronary syndrome patients with AF, what is your approach? Triple therapy for 3 to 12 months, triple therapy for 1 month, dual therapy for 1 month, and then single oral anticoagulation, or dual therapy since the PCI. Please vote. While we vote, of course, I want to congratulate Thomas for your excellent presentation. It was really a very didactic and very schematic presentation. I think it's very important to have somebody like you. You have all the evidence-based background, but still you feel, and I think that's the added value, that there is a complete need for an individualized approach, because if we just look at guidelines or some sort of organigrams, we won't have the ability to adapt to the patient in front of us. And actually, the combinations are so many that it's almost impossible to establish a clear pattern, and you were able to help us certifying a good plan. So I hand over to, I'm waiting for the televote results. Do we have it? We'll have them in a few seconds. So everybody chose the option B. So there is not much conflict over here. So I hand over to Jorge Guardado. Please, Jorge, thanks for being here.
So,
hello.
I've been clear. It's good.
Hello.
Good.
It's a pleasure to be here after the last night where he presented the case. My compliments to João Moraes, to you, and to all operators, and to Thomas, with an excellent talk about this topic of anticoagulant and anti-agrarian therapy. I just have here a question to you. Do you think there are some stents that could change this rule of the evidence basis in the triple therapy or in the double therapy and the duration of this? Do you think there are some stents that could, some kind of stents that could change our indication to have just 1 month or more, or limit the double anti-agrarian therapy?
Yeah. So first, to discuss the available evidence, I think we don't have evidence today to say that one stent can be used with 1 month of DAPT duration. We know we have leaders free senior saying that if you use 1 month, then this stent is better than bare metal stent. But let's say it's a device comparison study, and not DAPT duration. So my feeling is really that with the current generation DS, there is no much difference between the different platform, and I think you have to tailor the DAPT duration and the choice of DAPT based on the patient more than the stent, because thanks to the improvement of the DS technology, almost all the stents we have today in the shelf are very good and can be used with short DAPT duration if the patient need a short DAPT duration. But I will consider the choice of duration almost regardless of the stent used today. I know that the stent company love to use DAPT duration as the marketing argument, but my feeling, and based on the available evidence, is that it's not based on strong scientific evidence.
No, that's my opinion too, but I have to ask this because, like you said, this is a topic for the companies, and we have always the question if we use one or another stent when we want to do a short double anti-agrarian therapy or with the NOAC. So thank you for your response, and I could
thank you, Jorge. But please, before to proceed for the other members of the panel, but Thomas, let me ask you a brief question. I understand that you are not selecting antithrombotic therapy looking at the stents, or irrespective of the stent that you choose, you decide antithrombotic therapy. And the opposite, you select the stent looking at the bleeding risk, or looking at what kind of antithrombotic strategy you are using in the future. This means you select the patients previously.
Of course. In the opposite, I agree that if you first decide that you want to use short DAPT because you have patients with high bleeding risk, then you can use the leaders free, the senior, the Onyx one, to try to choose the stent which has been proved to be better than bare metal with short DAPT duration decided before. So I fully agree that if you take it in the opposite, I agree that we have to follow that.
Thank you so much. We are moving to the panel.
You do that when you have a patient who needs to be operated? You do the same.
Yes, for example, yes, planned surgery, oral anticoagulation, or elderly patient, or all these kind of things. Anemia, which is a strong predictor of bleeding also.
Okay. I would just add just a position. It's very frequent when I'm called to the cath lab by a fellow that they just show me the angiography, and I always tell them, but did you tell me what's their bleeding risk and because I'm looking at their ischemic risk, but you didn't tell me anything about the bleeding risk. And from my point of view, when you plan the procedure, for instance, you can adapt the number of stents, or for instance, the bifurcation strategy, or you can even change the profile of PCI versus CABG according to the bleeding risk and the ischemic risk. So it's very important that, I think the question was very pertinent, because it means that we cannot just do a PCI and then start thinking about what's the regimen that we're going to give to the patient. We have to do that in advance and not afterwards. And that's I think your talk was marvelous regarding that aspect. You just framed it very well.
Yeah. I fully agree. That's
So
one of the
I will
challenges.
hand over, João. I think we
Yeah.
can hand over to the other
Yeah.
panelists, please.
Thank you for your comments. Okay, in this panel we have 3 interventional cardiologists and 1 clinical cardiologist. Let's proceed to the clinical cardiologist, George Carvela. Please, can you take your
Hello, good
comments or
afternoon. Are
questions?
you
Or
listening?
hello?
Are you listening to
Yeah.
me?
Yeah.
Yes.
Yes,
Okay. Good
yes.
afternoon. Congratulations on the excellent meeting in a pandemic world. The Santa Cruz and the committee is in congratulations. I'm thankful for the invitation for participate in the meeting. It's an honor for me. I would like to say some words. The antithrombotic therapy is now up and down. For many years, we have seen more antithrombotic therapy, less antithrombotic therapy in the same patients. I think now we are in a phase that we are afraid of more antithrombotic therapy. And the last guidelines of atrial fibrillation and acute coronary syndrome said that we must have concerns about hemorrhagic and antithrombotic therapy, and we are doing less than we were doing in the past. We are not taking clopidogrel and prasugrel and ticagrelor before cath lab. We are concerned about doing NOACs in patients with atrial fibrillation, with trauma and intracranial hemorrhage, and we didn't have this information in the past. And I think we are in today. We are in the phase that we do less in concerns of the antithrombotic therapy, and I think it's good for the results of our patients, and we can do a work in clinical cardiology and interventional cardiology. Must be in the we just have concerns in clinical cardiology and interventional cardiology. We must have some information regarding all aspects of the patient, and an individualized therapy is the best. I would like to say that in the reports of the interventions, I think it could be better concerned about what we are going to do about that patient regarding the duration and the choice of the dual antiplatelet therapy and NOACs if we need. Because in 95% of all reports, we say at least 12 months of dual antiplatelet therapy. But as we know, it's not all patients are in this box. And I would like to share with you that we must do something more regarding the reports of the interventional cardiology and what is the choice of the patient to do some different schemes of dual antiplatelet and triple therapy. That is my words. Thank you.
Thank you, George. This is an interesting point, Thomas, because you know that in the past, one size fits all. Okay, everybody is after a stent 12 months or aspirin plus clopidogrel. But nowadays, it is clear in the show very, very clearly that we need to individualize the strategy. For every patient, we need one strategy. So the question from George is really interesting because when you write your report at the end of your procedure, probably you should suggest an antithrombotic regime. Well, what do you think? What are you doing in France?
Yeah, I think that's really a very good point. And for me, let's say the DAPT strategy is really part of the PCI report. Meaning PCI report will be the access, what I found, what I did, and what will be the plan for DAPT strategy. And really, of course, we know, as I said, that it can be changed because of the tolerance or because of the patient outcome. But I think for the referring physician, it's key that at the end of the PCI report and also at the end of the report when the patient is discharged, I'll always say to the resident, to end the lecture saying that the plan for DAPT is aspirin and prasugrel 1 month, and then aspirin and clopidogrel. And now we tend to do exactly the same for the lipid lowering strategy. So meaning when we have patients with coronary artery disease, either stable or unstable, at the end of the lecture, we have 2 boxes, one for the antithrombotic strategy and one for the lipid lowering strategy. That's what we did in my center. And I think it worked quite well for the communication with the referring physician, but also for the teaching of the younger doctor, I think.
Thank you, Thomas.